So this has been funded by a $64 million NIH grant, and it has been described as the largest grant in palliative care history. So what makes this moment different maybe from prior funding initiatives or efforts? And why is this such a watershed moment?
The way that we set up the budgeting is we set it up so at least half of that money is going back out the door. It's going back out the door to support pilot grant awards and to support research scholar awards, junior investigators. So it's truly an investment in the field. So I would say one of the truly transformational components of this U54, which is the NIH mechanism that's funding ASCENT, is this true trans-institute strategy within NIH. I actually don't know that I've ever been so nervous as when we pushed the send button. We got our score in November of 24 because it went to study section like all NIH proposals do. So we first had to go to study section. We got our score in November of 24. And I will say my first thought when we actually got the funding was we just gave a lifeline to all these palliative care researchers across the country. As we're practicing, I wish I had evidence for what is most effective to treat this symptom, how I best reach this hard to reach population. And I think that's where we really need to push the field to that next level of research. So we can amplify what we already know by speeding that time from evidence generation to implementation, which requires a rigorous and thoughtful approach. If we could get to the point where there's no longer these gaps in the care continuum for people with serious illness and those who care for them. I think those of us that are deliver care either as clinicians or as organizations well recognize that there's pockets, hospice, there's inpatient palliative care, there's some palliative care clinics, and then there's these big gaps in between. I think we have to keep pushing toward it, is that in 10 years, our research questions and the things that we're studying are actually refining care rather than addressing what are really still basic gaps in care that exist today. And then I think also for palliative care research to be seen as an actual viable career pathway for all palliative care relevant disciplines. We are doing this because people living with serious illness and those who care for us are depending on us to develop that evidence to make sure that they have the best care possible. That's really our North Star. I'm a firm believer in applying palliative care principles to leadership, like seek first to understand, identify shared goals, really listen. Those sort of palliative care principles that we're so used to from a clinical sense, applying those to actually making this work.